The SURTAVI is a trial with the core valve versus surgery in the intermediate risk. After the high risk and the inoperable, we went to the intermediate risk. And when we went to see the FDA said intermediate risk is between 4 and 10%. And we started the trial in Europe and United States, but the recruitment was already difficult because already in Europe there was some dysregulation and the people were doing more easy patients. So halfway in the trial, we went back to the FDA and said, can we modify these 4 to 10% STS, which is strictly a code of the surgeon? And they agree, and we went to equal 3% of more than 3% defined locally by the surgeon and the interventional cardiologist. And to do that, we had a long list of being a strong patient, of a weak patient, all the weakness which are not in the STS, but are clearly frailty argument that you have to introduce in your judgment. So there was a list of frailties which was had to the STS. And there was a kind of dysregulation because it was 3% in the hospital. But then nevertheless, we keep recording the official STS. And that's how we generate a reasonable cohort of patients with an STS below 3%. And then we divide the population in 5 equal groups, and we realized that that population with less than 3 STS was doing extremely well. As a matter of fact, in terms of stroke and death, the two key major cardiac events, we were superior to surgery. There was a p-value. It is small numbers, it is exploratory, it's post-hoc, everybody agrees with that, but it has already generated new plan for low risk. Yeah? And that's the key point coming from these sub-analysis of the SURTAVI in the less than 3 STS. If it has changed the practice, yes, I think that obviously in Europe there is, and in the United States, there is a kind of dysregulation. First of all, the STS does not predict correctly the mortality. It's a little bit by chance that we found some prediction for the 1 year, but 30 days certainly not. And this is something that you cannot stop. I mean, you see basically people treating patients with low risk. Lars Sondergaard from Scandinavia has presented his 5 years notion, which was an STS around 3, and there is absolutely no difference at 5 years. And what was not my surprise yesterday when I look at the slide on structural deterioration of the valve is that in the percutaneous it was 0, and then in the surgical you could see a multiple step. And I asking what happens, and basically they are already implanting small valve because they have to remove the calcium, they have to implant it. You have sometimes some pannus which is growing on the set, and these valves get reduced in surface and they develop a gradient. So it was not by leaking, a valve leaking, of having regurgitation, was mainly because there was again a gradient. So that's fabulous information, because the whole issue in lowering the level for SURTAVI is of course the durability. And you remember 2 years ago at the EuroPCR there was this movement of panic saying, oh, that they get all worn out at 7 years. I'm just coming from a session where you see all kind of valve. Obviously, there are geographic variation. If you go to China, you have extremely calcified valve, bicuspid. So clearly, you need a material with much more radial force. So you should have a lot of respect for the Chinese valve, because they are targeting these highly calcified big speed valve, we try to reduce the diameter of the catheter. You know, we start with 24 French, we are now in the 16, 14, we try to go in 12. And with many other people, I try to work on a bioresorbable valve. That's what I present today, because all these valves are coming from bovine, porcine, equine. They have been somewhat sterilized in glutaraldehyde, which deteriorates some of the biological material. So if you operate somebody with a bioprosthesis below the age of 50, you have 40% chance that within 20 years you will be reoperated. For us, it's already different. We can put a valve in the valve and even break the valve of the surgeon. It happens, but ideally it should be all tissue. It should be all tissue with its nutrient. So what we have developed is a biodegradable material who get colonized and covered by our own tissue. It's, of course, as usual, the dream. It can take a decade, maybe 2 decades, but the idea is good. There's no doubt about that. We just need a transient template to have our own tissue. We call that endogenous restoration. That's something we could have some future and simplify the problem of durability. It's very interesting because the FDA didn't have this time the test of durability. It's saying it's bioresorbable anyway, so why should we have the test of durability? But it will be another kind of durability, of course.